Module 11 is about neurologic and sensory disorders. So, a brief review of the anatomy and physiology of the nervous system. The nervous system has two parts, so we can break it down into the peripheral nervous system and the central nervous system. The peripheral nervous system, we can further break that down into two other parts, the somatic or voluntary system and the autonomic or involuntary system. So you probably remember the somatic system is responsible for voluntary movements, sensations, and things like that. It has afferent fibers with an A. Those fibers carry info to the brain, and then efferent fibers with an E carry info from the brain to the body. Then the autonomic or involuntary nervous system is responsible for involuntary actions that we don't necessarily think about. So things like our heart beating, our breathing, digestion, sweating, salivating, things like that. The sympathetic nervous system is a part of the autonomic nervous system, and that is responsible for the fight or flight response. And then the parasympathetic nervous system is responsible for rest and recuperation of all of the body systems. If we're talking about the central nervous system, that is just the brain and the spinal cord. We can, of course, further break down divisions in the brain into three main sections, the cerebrum, the cerebellum, and the brainstem. And of course, we can break down the different lobes of the brain if needed. A couple things about reflexes. If a baby has primitive reflexes that are absent, so say they never have the palmar grasp or they never have the Babinski, it could be a sign that there is a central nervous system problem. If they have a persistent reflex, like for say the Babinski reflex lasts longer than 12 months, it could indicate a frontal lobe problem. If we're assessing a child's deep-tended reflexes, which I know we don't do that often, but if they have a decreased response, that could be a peripheral nervous system problem. So say we try to do their patellar reflex and we don't really have much response or it's very mild, could be a peripheral nervous system problem. If it's an exaggerated response or super brisk, like their leg just kicks out very violently, could be a central nervous system problem. Of course, this isn't going to be the only symptom that they have, and it would be a part of other symptom clusters if they had these specific problems. If we are assessing a child with a known or suspected neurological problem, we can ask questions to the child or the parent about the birth history. So was there any birth trauma? Was there any asphyxia at birth that could have deprived oxygen to the brain? Was the child premature? What was their weight at birth? Things like that. Do they already have any specific diagnoses that could be related? Have they had any surgeries, especially on any part of their nervous system? Have they had any accidents? Things like have they had concussions before or hit their head? Any illnesses? Have they been meeting their milestones as expected? Any behavioral issues, like are they excessively aggressive? Do they have any problems at school? How's their interaction with other children? What's their activity level? Parenting variations, so who do they live with? Is it their biological mother and father, or are they in foster care? Are they being taken care of by their grandparents, whatever? What's their socioeconomic status, or are there any issues? Are they homeless? Are they below the poverty level? Do they have access to health services? On physical examination, we can, of course, measure their head circumference to see if they have microcephaly or macrocephaly. So basically, a head that is too big or too small. Technically, microcephaly is where the head circumference is more than 2 standard deviations below the average for the child's age, sex, race, and period of gestation. Same with macro, it's 2 standard deviations above the average. Does the child's muscle tone, is it hypertonic or hypotonic? So increased muscle tone or decreased muscle tone? Do they have evidence of any muscle wasting or atrophy? Do they have any skin lesions? Do they have any dysmorphic features like low-lying ears, a flattened nose, any abnormal eyelid creases? Do they have any cranial nerve abnormalities? So when we're doing any of those testing, such as on their facial nerve or their extraocular eye movements, anything like that, that is abnormal. If we do a developmental screening, are they meeting their milestones as expected? And what are their motor skills? So what are their pushes and pulls? Can they stand on one foot? Can they run? Depending on their age. To diagnose different neurological abnormalities, we can do things like chromosome testing, metabolic screening, such as the newborn screens, thyroid testing, and MRI. MRI can show us things like, is there any actual structural problems in the brain or any sort of injury? Treatment-wise, of course, it depends on for all the different disorders that we're going to talk about. But for most of them, we need a multidisciplinary approach. So the child may need services like physical therapy, occupational therapy, speech therapy, audiology, child life specialist. And we also want to treat any associated conditions. So sometimes some conditions may go together. They may have endocrine issues because of their neurological issues, for example. The first disorder we are going to talk about is spina bifida. So spina bifida is a type of neural tube defect. It's the most common neural tube defect. So neural tube defects occur in the brain and spinal cord during fetal development. They're thought to be due to folic acid deficiency. So that's why it's recommended that all women of childbearing age take folic acid before and during pregnancy. Closure of the neural tube occurs around the 1-month mark of gestation. So many people don't even know that they're pregnant at that time. So that's why it's recommended to take it before you're pregnant, because a lot of times this can happen before the person even knows that they're pregnant. So there's 3 different types of spina bifida. So the first type is called myelomeningocele. Another word for it is spina bifida cystica. This is where a section of the spinal cord and the associated nerves around the spinal cord in that area are actually exposed and visible on the outside of the body. So this can cause partial or complete paralysis before the opening. So basically like above or below where the opening is, if that makes sense. So it's not necessarily like the person is paralyzed like a quadriplegic, but usually it's the lower part of the body. This can be removed surgically, but that doesn't correct any deficits that the child may have. So if they do have paralysis of their legs, it's not going to just magically resolve the paralysis necessarily. They could also have other symptoms like problems with control of the bowel and bladder are also very common. A meningocele is where there is a membrane that's surrounding the spinal cord is enlarged and it creates a sac. So this one, the sac is present on the back and it contains these meninge fibers. Sometimes this one's a little bit smaller and it might not always be visible on exam. This one doesn't always cause disability, but it can. So they do still have the potential to have paralysis or some degree of muscle movement problems or sensory loss, but it doesn't always cause that and is usually more mild than the myelomeningocele. This one also can be surgically removed, but it also does not correct any deficits that the child may have. The most mild version is spina bifida occulta. So occulta means hidden. This one, there's a section of the spinal vertebrae is malformed, but the cord and the nerves are basically normal. This one, you can't really see anything from the outside, so there's no sac of meninges or anything that you can see. But this is why we look for the sacral dimples and the tufts of hair in the dimple, or even any hemangioma in that sacral area. This could be a sign that the patient does have spina bifida occulta. This one's usually found by accident. A lot of people don't notice the sacral dimples, especially parents, and sometimes they actually don't have either of those things. And it may be found by accident if the patient has, say, an MRI for some other reason, like maybe they have an injury and then they see it on MRI. A common version of this is called a tethered cord, where basically the tissue attachment at the bottom of the spinal cord, it's like tethered in an incorrect sort of way that prevents movement. So it limits movement of the spinal cord within the spinal column. So sometimes children with spina bifida occulta have very mild symptoms. They may appear clumsy, or they may have bowel or bladder control problems, but they're usually very mild. A lot of people go their entire lives not knowing that they have this. So treatment for spina bifida. So if you're at the delivery or taking care of a baby with spina bifida, one of the first things we want to do after the baby's born is immediately cover the defect with a sterile dressing soaked in warm, sterile, normal saline. So sort of similar to the babies with phalocele or gastroschisis, we want to keep this sac that's protruding on the outside of the body moist so that it doesn't dry out. We also want to position the baby prone on their stomach. We also want to have their hips sort of flexed up underneath them and lying on an open diaper. So the picture on the top right is a good example of that. Basically, we don't want their legs just straight out back behind them because that's not developmentally appropriate for a baby. We also want to measure a baseline OFC, or a baseline head circumference, and then continue to monitor for that. So one of the complications of spina bifida is hydrocephalus. So we want to make sure that the head size isn't growing rapidly. So we're going to be measuring that frequently. They're also going to be put on antibiotics to prevent infection, so most likely IV antibiotics. They're going to have an immediate consult for pediatric neurosurgery. So almost always we are going to be able to see this on ultrasound. So it's going to be known before the baby is born. So this may already be set up, but pediatric neurosurgery is going to immediately come and see the baby and give more specific orders. They're going to need consult and follow up with neurosurgery after their surgery. And they're going to follow up with neurology, PT, OT, social work, speech therapy, and possibly child life specialists. So since they can have some of these problems even after surgery, things like paralysis, problems moving, they could also have problems feeding, they are going to need extensive follow-up over time. But once the baby is stable, they will be going to surgery to have this removed. But again, that's not going to correct any deficits that the child may have. Like I said before, all females of childbearing age should take folic acid to prevent spina bifida. When we're looking at these pictures on this slide, the picture on the top left is a good example of a very deep sacral dimple, if you haven't seen one of those before. So you can see the baby's little butt crack, and right above that is a super deep dimple. Sometimes you can't even see really the end of it just with the naked eye. They'll usually do a spinal ultrasound of that to see if the baby does have spina bifida occulta. On these other pictures here, I don't know just by looking at it if the child has a meningocele or a myelomeningocele. I can't tell just by looking at it. It could be either one for both of these where the baby has a sac on their back. But as you can see, the sac can be fairly large, and we of course don't want to get any sort of infection in that area before the baby goes to surgery. So we want to keep the area clean. We want to keep the area away from any stool since it's near the diaper. And we want to keep the area moist with the sterile saline-soaked gauze or some sort of dressing. Again, the neurosurgeon is going to come by and give you specific orders for what they want. Two other types of neural tube defects are anencephaly and encephalocele. So anencephaly is where a neural cord defect where the majority of the brain doesn't even develop. So the baby can be missing both portions of the actual brain and portions of the skull. So this picture in the middle here of the baby in the striped onesie is a baby with anencephaly. Most babies with anencephaly are miscarried or stillborn or die very shortly after birth. So if they are born alive, they usually don't live very long at all. This picture of this specific baby in the middle of your slide, his name was Jackson, and he actually lived to be 5 years old. He had a pretty big social media following because he did live so long with anencephaly. I know you can't really see the top of his head, but you can see that basically the top portion of his brain is missing, and it does look like some of his skull is missing because you can see it doesn't look like it's the correct shape. It kind of appears a little bit soft there. The rate of anencephaly has decreased by about 28% since the US started fortifying grains with folic acid. So now it's somewhere around about 3 out of every 10,000 pregnancies. So not very common. But if the baby does basically survive birth and any time after that, they are going to be severely disabled. Encephalocele is another neural tube defect where a portion of the brain is protruding through an opening in the skull. So the opening in the skull can be in different areas. So these other two pictures on the screen, the top and the bottom picture, it can be a groove in the middle of the skull between the forehead and the nose, like that top picture, and on the back of the skull. Me personally, the only ones I've ever seen are on the back of the skull. The severity depends on where the location is and, of course, what's contained in the sac. This can be removed, but the babies may have deficits, again, depending on what portion of the brain is protruding and where it is. But they can have deficits like paralysis, problems eating, problems with bowel control, problems with bladder control. Chiari malformation is a structural defect in the cerebellum. So if you remember, the cerebellum is the part of the brain that controls balance. Also, there is a problem with the bony space at the lower part of the skull. It's smaller than normal. So this causes the cerebellum and the brainstem to be pushed downward, and the pressure on the cerebellum can then block the flow of spinal fluid from flowing correctly into the different ventricles in the brain and down to the spinal cord. There are different types of Chiari malformation. So type 1, there's usually no symptoms. The person usually doesn't know that they have it. It's frequently diagnosed by accident, say if the person has an MRI for some sort of accident or something, or being evaluated for another condition, they see it on MRI. This person could have very, very mild symptoms, but usually none. Type 2 is also called Arnold-Chiari malformation. This one, there is a larger downward herniation of the cerebellum through the foramen magnum, which is in the bottom of the skull, into the spinal column. So if this person were to have an MRI, they would basically show herniation of the cerebellum down into the spinal column. This one actually frequently accompanies myelomeningocele. So sometimes if you have a baby born with a myelomeningocele, they'll have an MRI, and it'll also show that they have Chiari malformation type 2. Type 3, it's just a little bit worse, so these sort of get worse from type 1 to type 4. Type 3 is associated with occipital encephalocele, so the encephalocele that is basically in the back of the skull. So this type 3, again, if the baby is born with this type of encephalocele, they have an MRI and it may show that they have Chiari malformation type 3. Type 4, the child usually doesn't survive infancy. With this one, there's an underdevelopment of the cerebellum called cerebellar hypoplasia. So this one, the cerebellum's in the correct position, so it's not herniating down, but parts of the cerebellum are basically missing, and usually these infants do not survive infancy. So some general symptoms of Chiari malformation can be things like dizziness, weakness, numbness, vision problems, headaches, and of course, balance and coordination problems because we're dealing with the cerebellum. These patients also have a potential for a cyst to form in the spinal column, which is called a syrinx or syringomyelia, which causes numbness in the lower extremities. So these symptoms can range from mild to severe depending on what type of Chiari malformation the child has. And then again, if you remember that they can also have myelomeningocele or encephalocele along with this, some of these symptoms can be compounded by things like trouble walking, trouble crawling, trouble moving, trouble eating. Diagnosis, like I already said, a brain MRI will show protrusion of the cerebellum down into the spinal column. Treatment for these, since type 1, a lot of times people don't know they have it or they have no symptoms, there's no treatment that's usually needed. Type 2, this one may or may not require treatment depending on the degree of protrusion. So depending on how far the cerebellum is protruding down into the spinal column and how severe are their symptoms, they may or may not need treatment. Type 3 and 4 may require surgery to decompress the cerebellum and basically create more space to minimize their symptoms. So basically, if you can imagine that there's a lot of pressure on the cerebellum and sometimes other areas of the brain, basically the surgeon has to go in and decompress the brain. So sometimes they can also have hydrocephalus, which could be another complication. For these type 2, 3, and 4, we want to prevent any injuries, and it's usually recommended that these children don't play any contact sports because we don't want them to basically ever have any sort of head trauma, any sort of brain trauma, because it could be magnified for these children. A couple different congenital malformations. So one of them is agenesis of the corpus callosum. So the corpus callosum is the structure or bridge that basically connects the two hemispheres of the brain. And in this disorder, that structure is either partially or completely missing. So this is the most common brain malformation. The symptoms with it can range from having absolutely no symptoms to having mild differences in learning, mild learning disabilities. They could have some forms of mental retardation. They could have hydrocephalus and seizures. A lot of times, though, people don't even know that they have this. This defect can occur alone or with other defects of the brain or other malformations like facial malformations. Microcephaly I already talked about for a second, but this one, again, is where the head circumference is more than 2 standard deviations below normal. So the brain has basically not developed properly, or at some point it stopped growing for some reason. This may be present at birth. So when the baby's born, you measure their head and it's already 2 standard deviations below normal. Or it can develop later where the baby is basically, their head is not growing properly, but maybe the rest of their body is. This is associated with some different things. So with Down syndrome, sometimes the babies can have microcephaly. With other different chromosomal abnormalities and different syndromes. But it's also associated with maternal substance abuse, maternal CMV, which is cytomegalovirus, Zika virus, rubella, or chickenpox exposure. This often causes delays in development. So if you can just imagine the baby's brain being too small, The baby just basically can't learn and develop normally. They may not be meeting their milestones at the expected time. It can also cause dysmorphic facial features depending on how small the head is. So this top picture here is a baby with microcephaly. It has pretty normal facial features, but if you could imagine if the head was even smaller, it can start to distort things like the eye shape. It can also be associated with things like hyperactivity and seizures. So for this one, microcephaly isn't going to cause the baby to necessarily die or anything like that. But again, they may be delayed in certain areas of life. So it's just supportive care. We can refer them to early intervention where they can start early, basically on anything that they need, like PT, OT, help with any sort of developmental milestones and working up to those. When they start to talk, going to speech therapy, when they start to go to school, special programs that they can be enrolled in. The last one is craniosynostosis. This is where there's premature closure of the sutures in the skull that results in abnormal head shape. So we all know that when a baby's born, the sutures are not closed, which allows the baby's head to grow over time. So this one, they basically close too quickly. So then the baby's head can't grow normally and their brain cannot grow normally. So this one's also associated with facial deformities, but it is possible for surgical correction of this to be performed in infancy, where basically they have to go in and make new suture lines. Hydrocephalus occurs when cerebral spinal fluid collects in some sort of abnormal pattern in the brain. So this can cause an enlargement in the ventricles called ventriculomegaly, which then in turn can cause too much pressure on the fragile tissues in the brain. So there's 4 ventricles in the brain, and they're connected by these different narrow channels that basically allow the CSF to drain and be reabsorbed in the bloodstream. So if there's some sort of increase in the normal amount of CSF, then the result can be hydrocephalus. So there's different types of hydrocephalus. Congenital hydrocephalus occurs before birth, and it can be seen on ultrasound. So this could be due to something like if the baby also has one of the forms of spina bifida, if the baby has one of the Chiari malformations, they could have this. If the baby has some sort of structural defect in their brain or in the ventricles of the brain or the spinal cord, it could cause hydrocephalus. So on prenatal ultrasound, when they're looking at the baby, they do measurements and they can measure and see that the baby has hydrocephalus. There's also acquired hydrocephalus, which would occur either at birth or after birth, which can be obstructive. It's often caused by damage to brain tissue, so that would probably be the one that's at birth, so if there's some sort of birth trauma. But it could also be caused from infection, so if the baby has something like meningitis, it could cause hydrocephalus. So there's a lot of different symptoms that the baby can have that have to do with a rapid increase in intracranial pressure. So the baby can have an increase in their head circumference, or the OFC, usually very rapid and way beyond what we would expect for normal growth of the head. They can also have a bulging fontanelle. Because of the increased ICP, they may have vomiting, they may be lethargic, extremely irritable. Their cry is very high-pitched and shrill. They could start seizing. One sign is called sunsetting eyes, which this baby has in this photo. Basically, it looks like the baby is looking down, but it's an involuntary movement. They're not trying to necessarily look down. And it's called this because I guess basically their irises and their pupils look like little sunsets. Sluggish pupils, if you were to do Perla, they could start bradying. They could also have tachycardia on the other end of the spectrum as the pressure continues to increase. They could have hypertension. They could have apnea and stop breathing. Abnormal posturing, like the decerebrate posturing. They could have a headache, and blurred vision. So to diagnose hydrocephalus, the baby can have a brain MRI that would possibly show the cause of the hydrocephalus if it's not already known, and how severe it is. Again, this can be seen on prenatal ultrasound as well. So treatment for hydrocephalus, one of the most common treatments is a VP shunt. So a VP shunt, it stands for ventriculoperitoneal shunt. So this shunt basically diverts the flow of the CSF from the brain to the peritoneal space of the abdomen, where it can then be reabsorbed by the bloodstream. So again, remember there's basically too much CSF in the brain, so we need to get rid of it somehow. So if you're looking at this top diagram, there's basically this tube that's placed in one of the ventricles of the brain, and the tube goes under the baby's skin and all the way down into their abdomen, into the peritoneal cavity. So basically the extra CSF just drains into their peritoneal cavity and then it's absorbed into the bloodstream there. There's also a different type called a VA shunt, where instead of ending in the peritoneal cavity, it ends in the right atrium of the heart. So it basically goes directly into the bloodstream that way. The VP shunt is a little bit more common. So for this one, before a baby would go to surgery for a VP shunt, we want to do frequent assessment of the vitals. Like I said before, with all the different symptoms they can have with this, they could have bradycardia, tachycardia, apnea. We need to be very closely monitoring their vitals. We need to be frequently monitoring their OFC. So we need to have a baseline OFC. So then when they come back from surgery, we'll see, did that decrease? And we just want to keep monitoring that. We want to, of course, assess their fontanelles. So is it bulging before surgery? We don't want it to all of a sudden start bulging after surgery. And also any suture lines that we can see. Sometimes if they have hydrocephalus, we can assess the sutures. You may see that the sutures are very, very far apart. So you can basically palpate with your hand that the sutures of the skull are extremely far apart because of the hydrocephalus. Post-op, so when the baby comes back from getting a VP shunt, we want to continue assessing for signs of increased ICP and any sort of shunt failure. So do they all of a sudden have a rapid onset of vomiting, a severe headache, which yes, it's sort of hard to ask a baby if they have a headache, but do they seem like they're in pain? Are they irritable? Are they lethargic? Are they excessively tired? Can we see actually any CSF leaking from the shunt valve area, which is usually right behind the ear? So they're basically going to have a little wound there from the surgery behind their ear where it could be leaking from there. We want to teach the parents about any home care and what to look out for. So again, we can teach them to look out for these increased ICP symptoms. We can teach them to look out for the shunt leaking. We can, of course, teach them to monitor any wounds from the surgery for redness and drainage. We also want to monitor for symptoms of the shunt draining too aggressively. So the baby could also have a headache then. They could also have nausea and dizziness. So it's basically like too much CSF is draining out more than what we would want. Also, when they come back from surgery, we want to have them in basically a semi-Fowler's type position with their head midline to minimize any sudden changes in their intracranial pressure. So just having the head of bed very slightly elevated, and we want to keep them midline, so not necessarily on one side or the other or on their belly. Of course, we want to give them pain meds because they're probably going to be in pain, but we also want to reduce any crying that they may have because crying can increase their ICP. So if they are vomiting, we would want to give them anti-nausea medications. If they're in pain, we want to give them pain medications because we don't want them to be crying or vomiting. We don't want them to be coughing or things like that. Home care of the VP shunt, again, we can educate on signs and symptoms of increased ICP and infection. Usually they can only have sponge baths until the surgeon okays tub baths. So just quick, more wipe downs instead of submerging the baby in a tub. We can give the parents education on treating their pain with any over-the-counter medications if needed. They can resume most activities besides swimming and contact sports. Now, you may be thinking, isn't this for babies? Yes, usually, but they do need shunt revisions over time. So as the child grows, basically the tube isn't long enough anymore. So they do have an extra link that they put in the child's body to allow for growth, but it's only so long. So then once it's too short, they have to get a shunt revision. Or of course, if there's any problems with the shunt where it's not draining properly or too aggressive, they may need to get a new one put in. So they usually need a shunt revision up until they're approximately 80% of what they estimate their adult height is going to be. So usually this isn't very often. It's only once or twice every 10 years. So they're not getting a new shunt put in every year, for example, maybe once or twice, and then they're done. Infants, though, can be held and handled as usual. This bottom picture here, you can see where the baby's head was shaved, and then you can basically see where the shunt is sort of popping out of the side of the skull. The shunt travels along the back of the ear there, so you can actually palpate it. And then again, I don't know how old this picture of this baby shunt is, but behind the ear there may be a surgical wound. There may be one on the top of the head, and then other various places on the abdomen. Sleep disorders in children are fairly common, and they not only affect the child's rest, but also their behavior and their learning ability as well. Most children will eventually stop these behaviors, they sort of grow out of them, but they can be very disruptive to both the child and the family, including parents and other siblings. So children can have insomnia just like adults, could be transient or chronic, where they simply just have problems falling asleep. They can also have problems staying asleep, so they could be awoken throughout the night several times, or maybe they're waking up very early in the morning, like inappropriately early. Also, sleeping at any inappropriate times. Examples could be hypersomnia, where they have excessive sleepiness, or narcolepsy, where they have excessive sleepiness along with daytime sleep attacks. Children can also have sleep apnea. Usually for children, they can have obstructive sleep apnea because of enlarged tonsils and adenoids. So it's the most common reason for a TNA. They could also have sleep apnea if they are obese. Limb movements in sleep. So they could have periodic limb movement disorder, which is where they have unusual limb jerking that limits their ability to sleep restfully. And also restless leg syndrome, where they have leg discomfort, such as pain or crawling sensations that limit their sleep. There's another group of sleep disorders called parasomnias. These are abnormal behaviors that are associated with sleep arousals. So examples of these are night terrors. So night terrors are sort of like nightmares, but more severe. They usually occur early in the night, in the first 1/3 of the night. The child may be screaming in fear. They may be disoriented upon awakening. The parents may be unable to comfort the child because they are so upset. Sometimes the night terrors can be triggered by something, like if they have a fever, if they are under a lot of stress, or if they do have sleep deprivation. The following day, the child doesn't recall any events of the night terrors. It can also occur in older children and adolescents if they are under a lot of stress or if they start consuming alcohol, but it's most common in boys aged 5 to 7. Also sleepwalking. So sleepwalking can occur during non-REM sleep, usually stage 3 or 4, usually early in the night. The child appears to be awake. Their eyes are usually open. They may be speaking, but it might not make sense. They can travel throughout the house, walk downstairs, open fridges. They may go back to sleep in an unusual place. If they are awakened during their sleepwalking episode, they're usually confused and disoriented. This tends to run in families. And usually these sleepwalking episodes are usually brief, just a few minutes, but they can last extended periods of time. Obviously, there is safety issues associated with this if the child does, say, go outside. There's REM sleep behavior disorder, where the child basically acts out their dreams violently while they're sleeping. This tends to occur near the early morning. And then, of course, nightmares, which are extremely common, usually occur in the early morning as well. The child remembers details of the dream with this one, so conversely with night terrors where they don't remember, and the child isn't confused upon awakening. Seizure disorders occur because of a sudden abnormal electrical activity in the brain. If the child has recurrent seizures, particularly when they are accompanied by abnormal EEG findings, where there's persistent abnormal brain activity, then the child could be diagnosed with epilepsy. But if they just have one seizure, they would not be diagnosed with epilepsy. We can classify seizures into different categories. So first off, we have generalized seizures. So generalized seizures are seizures in which both of the hemispheres of the brain are involved. So the abnormal electrical signal moves throughout the entire brain and not just part of it. Further breaking down generalized seizures, when most people think of a seizure, they think of a tonic-clonic seizure. Tonic-clonic used to be called grand mal seizures. So in this type of seizure, the patient has a rhythmic jerking of their extremities, and their extremities are also very rigid. They also lose consciousness, they lose awareness, and they may become incontinent. So when we're looking at the word tonic-clonic, tonic means rigid and clonic means rhythmic jerking. So basically the muscles are rigid and they also have rhythmic jerking movements of the extremities. Um, when these tonic-clonic seizures occur more than once, that may be a sign of epilepsy. So this is usually the type of seizure that people with epilepsy have. So this is usually treated with anti-epileptic medications. There's also absent seizures. So absent seizures used to be called petit mal seizures, and they're characterized by a loss of awareness or loss of consciousness, but there's no tonic-clonic movements. So sometimes the child may appear to be staring off into space or daydreaming. Sometimes they may also have very small movements, like lip smacking, chewing sort of motions, blinking rapidly, or even small twitches in their hands or feet. These absent seizures usually are super short, lasting only a few seconds, but they may have hundreds of them per day. There's no known cause for absent seizures, but they can be provoked by things like hyperventilation or stress. And absent seizures can be dangerous because the child is unconscious or lacking awareness during them. So sometimes these aren't recognized by teachers and parents, and they think that the child is not paying attention or that they're daydreaming and may actually be punished for it. Usually, most children outgrow these seizures by the time they reach adolescence, but sometimes this does develop into juvenile epilepsy. Then we have partial seizures. This one is just where we have abnormal electrical signals moving throughout a small part of the brain. So as in opposition to generalized seizures where it's throughout the entire brain. Then we have febrile seizures, which are a little different. So febrile seizures are basically convulsions that are triggered by a rise in the patient's body temperature. It's common in kids that are about 3 months to 5 years of age, and it's more common in boys. These seizures are usually infrequent. It may only happen one time or a couple times. They're very short, less than 5 minutes, and they don't cause any brain injury as long as they are short and infrequent. It doesn't increase the risk of the child developing epilepsy later. If the child does have a episode of a febrile seizure, we can basically just educate the parents to try to treat fevers promptly to try to diminish the risk of the child having another one. But even doing that, it may not totally prevent the child from having another febrile seizure. So usually these are sort of very scary for the parents, but the child isn't usually harmed in any way from the seizures. Seizure disorders are diagnosed with the use of an electroencephalogram or an EEG, which monitors the brain waves of the child, and we can see if those are abnormal, and they can diagnose, say, epilepsy from there. You can also do a brain MRI to see if there's any sort of structural abnormalities. Interventions for seizures. So, of course, the child can be prescribed anti-epileptics if they are diagnosed with epilepsy. At home. So if the child's at home and has a seizure and it lasts longer than 2 minutes, the parent should be prescribed, or the child should be prescribed, rectal diazepam gel that the parents or the caregiver can administer at home. So the diazepam gel is inserted rectally. It usually comes in this sort of pre-filled syringe or pre-filled enema type thing. That already has the correct dose, or the parent can actually dial the correct dose on it. So if the seizure lasts longer than 2 minutes, then the caregiver should administer the rectal diazepam. After the rectal diazepam is administered, if it's basically not working and now it's been longer than 5 minutes that the child has been seizing, then the caregiver should call 911 for help. There's also an intranasal Versed that's sometimes prescribed for at home also, but the rectal diazepam is much more common. If they are in the hospital, we can give IV lorazepam to stop a seizure if a child's having a seizure in the hospital. We also want to do certain safety measures, put them on seizure precautions. So if they're actively having a seizure, we want to turn the patient on their side to keep their airway open. And in case they do vomit, which is common with seizures, that they don't aspirate on their vomit. We don't want to restrain them in any way, and we don't want to place anything in their mouth. So we want to make sure that they're basically safe from injury from their surroundings, but we don't want to hold them down in any way because we could actually injure them more. We want to try to time the seizure and educate parents to time the seizures at home. So doing the best they can. Sometimes they may not see it at the very beginning, but it may be important for their plan of care how long their seizures are. We don't want to include the post-ictal period in the seizure time. The post-ictal period is immediately after the seizure when the child may be very, very drowsy, maybe even hard to awaken. Also at the bedside, if they are admitted, we want to make sure that we have safety equipment already set up at the bedside. So we want to have oxygen, we want to have suction already ready, we want to pad the bed with special seizure pads, or sometimes we just use pillows or blankets even. And they should already have IV access obtained in case they do seize and we do need to emergently give them IV lorazepam. Tics are a type of a movement disorder, and movement disorders are thought to be caused by a disorder in the communication from the brain to the muscles that results in unintentional repetitive movements. So tics can be either motor tics or vocal tics. So common motor tics are blinking, grimacing, neck jerking, shoulder movements, nose twitches, teeth grinding, and muscle tensing. Common vocal tics can be things like sniffing, clearing the throat, grunting, squeaking, humming, clicking the teeth, and sucking sounds. And then complex vocal tics are repetitions of words, syllables, shouts, or even obscenities. A lot of times people, if they see someone with a tic, may assume that they have Tourette syndrome, but there's actually a more mild sort of version of this called transient tic of childhood, which is a disorder of either motor or vocal tics that lasts for several months but doesn't last longer than 1 year. So it's more of a temporary type disorder that goes away pretty quickly And with this one, it's either motor or vocal. To be diagnosed with Tourette syndrome, the person has to have both motor and vocal tics, and they need to have been present for more than 1 year and have began before the child's 18th birthday. The most common motor tic is eye blinking, and the most common vocal tic is sniffing or clearing of the throat, which is sometimes misdiagnosed as just allergies. Sometimes these tics can worsen around age 12, but for most kids, these disappear completely by age 18. Certain things can worsen the tics for some children. Anxiety is the biggest trigger. They can also be a secondary symptom of things like infections, medication side effects, stroke, head trauma, and degenerative disorders. So most children learn to manage the tics on their own, and eventually over time they diminish until they are absent. For a lot of children, it's more embarrassing than anything. But again, like I said, most of the time these go away on their own before they turn 18. Meningitis is an infection of the nervous system, which is going to affect the meninges, which are the coverings of the brain and spinal cord. So this infection can be caused by bacteria, by viruses, even by fungus, or things like amoebas. It can be life-threatening and it should be treated as a medical emergency, especially if it is bacterial. So some common symptoms of this are very, very bad headache, a stiff neck, which is called nuchal rigidity, sudden high fever, sensitivity to light, a bulging fontanelle in a baby, altered mental status, so the person could be lethargic, even comatose, irritability, sleepiness, and a rash. Two different tests that we can do, or even the provider could do to test for meningitis. One is Koenig's sign. So with Koenig's sign, you have the patient flat on their back. You flex their hip up, and then when you try to basically move the knee or extend the knee 90 degrees, they have severe pain. Then there's Brudzinski's sign. So Brudzinski's sign is when you flex the neck, basically moving their chin towards their chest. It causes them to involuntarily move their knees and hips. So they involuntarily flex their knees up. To diagnose meningitis, we can do a CBC. So on the CBC, it would show an elevated white blood cell count. However, that's not going to tell us where exactly the infection is. So to identify that it is meningitis and what's causing it, we need to do a lumbar puncture to identify, is it bacterial or viral or fungal, or is it even meningitis at all? So some common causes of meningitis are things like group B strep and E. coli in newborns, and then for older children, streptococcus, Neisseria, and Hib. Treatment, we need to rapidly recognize that the person has meningitis. Usually it's pretty obvious by the symptoms that at least we're going to do these tests to see if they do have it. Usually we're going to start antibiotics, maybe even antifungals right away, even if we don't know if it's bacterial or viral or fungal yet. We're just going to start all of them, and then we can take away ones that we don't need later. So usually we're going to start with at minimum broad spectrum antibiotics. The child can deteriorate rapidly, especially if it is bacterial, which is usually much more severe than viral. So we need to have frequent monitoring of the patient and assessment. So if it is bacterial, they are usually admitted because it can be fatal if left untreated. Viral meningitis is rarely fatal. It usually resolves without any sort of medication. However, it can be very, very painful and just not a very fun time for the person. However, they may not need to be hospitalized. It sort of just depends on how severe their symptoms are. There are vaccines available for some types of bacterial meningitis that the patient may or may not have gotten depending on their parents' wishes. And there's ones that they can get before they start college that many people do not get. Meningitis should always be suspected in an infant that's acutely ill with a fever and lethargic until proven otherwise. So, if we have an infant or a very small child that comes in with a fever and is lethargic, a lot of times in the emergency room, they will go ahead and do a lumbar puncture to rule out meningitis just in case, um, along with blood cultures, also usually urine cultures just to make sure that it's not meningitis because of the risk of them so rapidly deteriorating. Cerebral palsy is a group of conditions that affects motor development in children, and it can range from very mild to extremely debilitating. So, cerebral palsy is the result of some sort of damage to the brain that happened either during birth, before birth, or even after the child's born. So if it was before or during birth, it's called congenital CP. And this can be caused by things like birth trauma, birth asphyxia, an intrauterine infection, hydrocephalus, things like that. Could also be after due to injury or illness. So, after if they had meningitis or had some sort of brain injury, it's called acquired CP. There's different types of CP. The most common that 70% of children with CP have is called spastic. So with this, they have stiffness in either their legs or arms or both. It can result in difficulty walking and a scissor-like gait. There's also dyskinetic. This one, they have difficulty controlling movements of the body. They can have sudden uncontrollable changes in muscle tone. So basically, they can switch from having hypotonia all of a sudden to being hypertonic. Or sometimes they have slow rotational movements of the arms and legs. There's also ataxic. This one, they have problems with balance and coordination, and a lot of problems with purposeful movements, with things like writing or eating or reaching for objects. They can also have mixed CP, which is a combination of two or more of these types. There's no cure for CP, it's not fatal. So treatment is aimed at early intervention and aggressive therapies like physical therapy and occupational therapy to help the child reduce their disability and maximize their potential and maximize their life. So they could be on several different medications to help. So things like muscle relaxants, anticonvulsants, even Botox is used quite frequently for spastic CP. They could have an orthopedic surgeries, making sure that they have the right equipment like a wheelchair or a stander or crutches, also things like massage therapy, acupuncture, and all the different types of therapies that they could participate in, like play therapy and music therapy, that can help maximize their potential. Spinal muscular atrophy, also called SMA, is a degenerative disorder of the anterior horn cells of the spinal cord that results in weakness and wasting of voluntary muscles. So, one of the initial findings of this is often lower extremity weakness. In milder forms, this is the most common neuromuscular disorder in children. However, it is also the most common recessive genetic disorder that is lethal in children. There are different types. So SMA type 1 is the most severe. It begins in utero or early in infancy. So on prenatal ultrasound, the infant may have very few spontaneous movements, or when the baby is born, they may not be moving very much. They might have trouble sucking and swallowing, so we need to monitor for aspiration, and they may not be able to eat, so they may have feeding tubes. They may have a loss of their deep tendon reflexes. They may be unable to lift their heads. They may have fasciculations, which are like twitching of their tongue and certain muscles like their deltoids, their biceps, and their quadriceps. The respiratory muscles are usually very weak, and death usually occurs by 3 years of age because of respiratory compromise. Infants who have these symptoms at birth, like right at birth or in utero, usually have a shorter lifespan and die before they're even 12 months old. SMA type 2 is noted a little bit later in infancy, usually manifests between the ages of 6 months and 24 months. Deep tendon reflexes are usually absent. They may or may not have these muscle fasciculations. The lifespan for these kids is a little longer at 20 to 30 years. SMA type 3 is a juvenile form of the disease where the onset is between 3 to 17 years of age. Early symptoms are sometimes nonspecific and may include delayed motor milestones. Atrophy of some of their proximal muscles may be present. Most of these kids usually live into adulthood. So to diagnose this, they could be diagnosed based on their symptoms. We can do blood tests for genetic markers. They can have an EMG, which an EMG is electromyography. Basically, they can put like little needles or sort of a probe in the muscle, and it basically assesses the health of the muscle and the nerve cells that control them, and also a muscle biopsy. Treatment for this is usually supportive care since unfortunately it usually is fatal depending on which type it is. So we need to monitor for aspiration and respiratory compromise since those are usually the causes of death. The last topic we're going to talk about is head injuries. So we can classify head injuries as minor, moderate, or severe. So a minor head injury, some symptoms that a child could have is they're temporarily confused. They could possibly have mild change in their LOC. They could have vomiting. They could look pale. They could be irritable, lethargic, or drowsy. The moderate head injury, they could start to have changes in their vital signs, definite altered mental status, focal neurological deficits, and they could have an increase in agitation. Severe is, of course, what we worry about the most. Symptoms with infants, they could have things like a bulging fontanelle, separation of their cranial sutures, a high-pitched shrill cry, not wanting to eat, sunsetting eyes, and distended scalp veins. Older children, they could have nausea, headache, vomiting, blurred vision, increased sleeping, inability to follow commands, and even seizures. Late findings basically means maybe the child had an accident and they weren't found for a while. So it's basically been a while since the head injury has happened and they're starting to get a little worse here. So they could start to have alterations in their pupillary response when we check for perla. They could start to have posturing, like in these pictures, the decerebrate or decorticate posturing. They could start to brady down in their heart rate, a decreased motor response, decreased response to painful stimuli, Chine-Stokes respirations, swelling in their optic disc and their eye, decreased consciousness all the way into coma. So testing for this, of course, we can do scans of the head, neck, and brain, like a CT, MRI. We can do cervical spine x-rays to see if there's anything going on with the spinal cord, and EEGs to look at brain waves. Interventions, we want to make sure we stabilize the spine. We want to monitor their vital signs and ask them questions about their level of consciousness. We can do PERLA. We want to maintain their airway and do whatever we can to decrease their ICP or at least prevent it from increasing anymore. So treating things like vomiting, pain, trying to reduce crying if possible, and coughing. Monitor for any excess fluid volume. During surgery, they could put in drains in the subdural area to drain off any extra CSF that's causing pressure. They could have a craniotomy, just basically making a hole in the brain to decrease pressure. Transfontanelle aspiration, basically they take a big needle and poke it through the fontanelle, and then they can basically draw off CSF through that way. Prevention is going to be the key. So we want to obviously, first off, prevent any head injury from happening in the first place. So promoting safety things like wearing helmets, wearing seat belts, using car seats appropriately, avoid doing reckless activities, and providing adult supervision.